Morning, everyone. I'm Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to presenter and me, the host, by using the chat panel. The button to open the panel is usually located in the upper or lower right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on FADAA's website within 30 business days. To access the recording and PowerPoint, go to www.fadaa.org, then to our Resource Center, and then to our training library. FADAA produces many workshops and webinars through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credits for webinars taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on FADAA's website. You will first need to register or sign into your account to complete the evaluation. Information you provide FADAA as a part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close at midnight, Tuesday, March 29th. Up to one continuing education credit is available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors arrivals and departures of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. And now I'd like to welcome our presenter, Albert Hassan. Albert has received his MSW from the UCLA and has worked in the field of addiction medicine as a researcher, treatment provider, and trainer since 1977. Mr. Hassan participated in the development of evidence-based matrix model and established the Matrix Institute on Addictions Los Angeles, an opioid treatment program serving individuals with co-occurring mental and physical health and substance use disorders. Mr. Hassan served as node coordinator of the Pacific Region node of the National Institute on Drug Abuse Clinical Trials Network, and as a project director and trainer for the Pacific Southwest Addiction Technology Transfer Center at the UCLA Integrated Substance Abuse Programs, where he trained mental health, corrections, and substance use disorder providers on motivational interviewing, cognitive behavioral therapy, contingency management, co-occurring disorders, and American Society of Addiction Medicine criteria and medications for opioid use disorder. Mr. Hassan is currently working as a private consultant. And now I'd like to pass the presentation over to you.
Thank you, Rebecca. It seems like there's a run-on sentence there that I'm going to need to fix. And sometimes it's not until you hear it anyway. Thank you very much. Appreciate your support that Eric and Eric provided. Today is the third of three in the series on stimulant use disorders, and we're going to talk about the trust. It's a treatment for individuals who use stimulants, developed by Dr. Rawson and colleagues of mine at UCLA and the Matrix Institute on Addictions. Our learning objectives today are to be able to describe really the basic components of the trust model, um, so to gain a better understanding of how we groups. It's not too different than how other CBT oriented programs would implement a group or an individual session. This trust could be folded in or melded into various levels of care as described by medicine. Trust was developed really at the request of Bob Hansen at the who was at the time worked for the single state agency on substance use disorders in West Virginia. And at that time, incentives, contingency management was really not approved. This was about 3 years ago. Contingency management was not approved by the Office of the Inspector General to be provided at a rate greater than $75, which it is now. And so given that $75 was the max, Bob had requested of Dr. Rossin and myself to look to develop an intervention specifically geared towards individuals who use stimulants. And so what we did was take aspects of evidence-based practices, an amalgamation, and put them together. Trust in and of itself is not evidence-based. It not gone through rigorous clinical trials through the NIDA Clinical Trials Network or any such blinded, not well, it couldn't be a blinded trial, but research trials, rigorous research trials to really determine whether or not it is evidence-based. The components of trust include motivational incentives at a rate of $75, and the Office of Inspector General has come out and has approved rates higher than that. In Montana, they're using $320 as a cap. In California, rolling a $58 million contingency management program across the state with a maximum of $599 to be sort of handed out, not handed out, but it's as an incentive for negative stimulant-free UAs, and that is a cap that they have on their program at this time. We've included aspects of cognitive behavioral therapy, the community reinforcement approach, motivational interviewing skills, and certainly anybody working in the field of substance use disorders has probably been exposed and been trained on multiple occasions in motivational interviewing. Though, as we know, MI is one of those skills that it doesn't have a long shelf life. It's one of those things that if you don't use it, you actually your ability to engage in motivational interviewing. Exercise, a lot of self-help, 12-step program, and or smart recovery, any sort of adjunct outside of the formal therapy and individuals and necessarily as a standalone program, but as a
Mr. Hassan?
Yeah. Hello.
Mr. Hassan? Hey,
Yes.
I'm so sorry, but your sound seems to be going in and out.
Oh, sorry about that. Let's
Problem.
see. Can you just give me 1 minute and see if I can make a change here?
Of course, of course.
Okay. All right. I'll be right back. Thanks.
No problem.
Okay, sorry about that. Let's see if we can try that again, okay?
You
Can you
sound
hear
much
me,
better now.
Rebecca?
Thank you. Yes, you
Is
sound
that better? Okay. All right. Sorry about that. Okay, so let's see. So these are the components: motivational interviewing, CBT, community reinforcement approach, MI, physical exercise, and augmenting sort of the formal therapeutic milieu with continued outside support. And again, it's not meant as a standalone. We don't expect programs to implement this to fidelity. You can add things, you can change things. It's available free of cost. And Rebecca, if you wouldn't mind, you can, I mean, you're welcome to distribute both the patient workbook as well as the counselor's manual to anybody that requests, or to anybody on these trainings. Let's see, the priorities really are to engage individuals in treatment, to be respectful, non-judgmental. What we do know is that, and with overdoses exceeding 100,000 for the previous 12 months, ending in February of this year, we know that people are better off in treatment than not. And so doing whatever we can, and Dr. Rawson, went over this significantly, or in detail yesterday, but keeping people in treatment is really crucial for one, longevity and quality of life. Providing incentives, and certainly providing, and we're not talking just necessarily about a cup of coffee or things of that nature, but providing incentives is crucial, and has been shown through multiple research projects, and that incentives are at this point probably the most effective form of intervention to be able to keep people in treatment, and also to help them along in terms of their recovery. And then really providing guidance and support for those individuals, with the understanding that there's cognitive impairment going on, keeping them in treatment as long as we possibly can, and with ultimately the goal to reduce and abstain from stimulants and other substances. In the manual, we have a therapist orientation. We describe how to utilize the groups and individual sessions. We review, there are topics that we provide direction on as it relates to whether it's in a drug cessation group or individual session, and it provides some background as to why the topic is important to helping individuals develop and sustain a recovery. It is a 12-week program with ongoing continuing care. As I mentioned, it can be used as standalone. You can embed it within an intensive outpatient program. You could utilize the materials also within a 3.1 or a residential program. But ultimately, what we do know is that substance use disorder is a chronic condition, and it's not going to be it's not going to be dealt with in a 12-week in a 12-week session, not whatsoever. Motivational interviewing, certainly being able to interact and engage patients who are more ambivalent than sort of the normal, and I shouldn't be using that word, but stimulant users are certainly ambivalent about the need for treatment. Treating them well, getting, understanding their condition, being empathic, is really crucial, and at the heart of being able to engage these individuals who are cognitively impaired, who have challenges to be able to acquire and retain new information. The patient orientation session, and aspects of role induction go back, 20 or 30 years. And one of the more crucial aspects of engaging an individual in treatment is the patient orientation session. When individuals know what to expect from a program, when they understand what is expected of them in terms of operating within a program, they tend to do a lot better. That's why having group rules and reviewing group rules, engaging patients in the development of the group rules, and allowing them an opportunity actually to enforce group rules is incredibly useful to engaging and retaining individuals in treatment. The patient orientation session, we talk about sort of what the patient's priorities are, what their goals in treatment are. We provide an overview of the individual and group sessions. We provide information about the incentive, the value of incentives, and exercise, the importance of exercise. We review what is called the calendar and stickers, or calendar and dots, and basically it allows patients to keep a diary on their substance use, on their engagement in exercise, and other sort of notable activities, holidays, or for that matter, anniversaries in their life. And so what it allows people to do is to create a sort of a visual roadmap of their successes and how well they've done in recovery. And then we usually end every session on scheduling, either begin or end a session on scheduling, so that people can create a roadmap for their recovery, so that they know what they're going to be doing from day to day as it relates to a schedule. And what we know is that people who are able to keep and follow a schedule tend to do better in recovery. The schedule provides a structure on an outpatient basis, much the same way that the facility in a residential program provides the structure for an individual. And so this allows individuals to keep track of what they're doing on a day-to-day basis. It allows the counselor to be able to monitor what people are doing during the course of their day, the course of their week, to determine whether or not they're engaging in safe activities, or for that matter, whether they're placing themselves at risk. And what we do know is that boredom is a significant trigger for substance use disorders, and so we want to help people to develop a schedule that suits their needs. And it ultimately is their schedule. It's not the counselor's or the therapist's schedule to develop. The incentive program, really, it's at the heart of any, or should be at the heart of any program that is looking to address stimulant use disorder. Dr. Rawson went over the evidence for incentives, and what we're seeing is that in many instances, many states are coming around and developing a formal incentive program to be implemented statewide. As we developed the trust incentive program, there was a maximum of $75. The individual orientation session really was, we provided $5 for attending that initial session. It's Medicaid compliant, and basically there was a $10 gift certificate given for every stimulant negative UA result, to a maximum of $75. Ideally, I think what's really important is to address the early dropouts. And so if you're able to, and we were encourage people to pack the $75 within the first month of treatment as a way to be able to retain people in care, because dropouts generally occur, within the first 2 to 3 weeks of treatment. Additionally, what we did was we provided a $25 gift card that wasn't part of the incentive program, but rather to gather information to determine whether or not the patients found the incentive program, or for that matter, the trust program, useful. Physical exercise, what we know is physical exercise shows positive benefits for both mental health and the treatment of substance use disorders, particularly anxiety and depression, reduced anxiety, reduced depression. We know that it improves cognitive functioning and reduced symptoms of anhedonia. And that is really the hallmark of what people who are going through treatment for stimulant use disorder experience, is that inability to experience pleasure. And so what I'd like to ask you all in terms of what is it that you do, and you can share in the chat here, what do you do to motivate yourself? I know that yesterday, people were talking about buddying up or including music along with, to help motivate the exercise. But I mean, what do you do to motivate yourself, and then ultimately, how will you encourage your patients to engage in exercise? So I'll let you go ahead and put some things in the chat box that. Okay, Francis. So Francis, you asked $75 in what time frame? So ideally, we wanted to pack the $75, within the first month or so of treatment. However, that being said, that $75, the limit on that is that $75 in a calendar year that people could earn. Ideally, what we want them to do is to be able to earn that within the first 30 days of treatment. So I'm going to let people, I don't see anything here on how you motivate yourself to exercise, but we'll talk a little bit about that, as we move on. Certainly what we do know is that buddying up is helpful. Engaging in activities that you used to engage in that feel familiar with you are useful. Using your children as sort of a source to exercise, getting out, going hiking, going to the park, going for a bike ride, those sorts of things are incredibly helpful. And anything that has helped you to engage in an exercise routine will potentially be helpful to any of the patients that you're working with. Let's see. Spiritual meditation, reading, church services, walks on the beach, making money. Yeah, health, my professional responsibility. Thank you, Francis. Yolanda says, I tell myself it's not optional. I really don't feel like it. Just walk down the street. Yeah, and sometimes, yeah, thanks for sharing that, Yolanda. Sometimes it's those times when you really don't want to do it that it feels most gratifying. Going out for taking the dog for a walk or volunteer at the Humane Society. Absolutely. When you're at the Humane Society or one of the food service organizations, sometimes they really do put you to work. Alice Marie says that coordinating yoga, Zumba sessions directly with the meetings times is really helpful. And certainly if you can get a twofer, having people come to your program and engaging them in recovery activities, and then sort of piggybacking along that, some Zumba or yoga, some sort of exercise routine is incredibly helpful. Thank you all very much for sharing that. CBT and CA, CRA, I talked a little bit about CBT and CRA yesterday, so I'm not going to spend a lot of time on this, but really what we're looking to do is to teach skills. What we're looking to do is for people to help people become students of their recovery, so that they can be aware of their surroundings, be aware of their emotions, how their emotions impact their behaviors, and thoughts as well. And so really what we're helping them to do is to become more aware of themselves in relation to their environment and to people around them, and ultimately to try to slow the process of triggering down. if we can help them to slow the triggering process down, they can, ultimately intervene in that process to such a degree to where they don't use, where they pick up the phone and call somebody for, or they can go out for a walk, or, do something around the house, or, that's really what we're trying to do, is engage them in behavioral activation to help them stop the triggering process, or reduce the impact of the triggering process. Continuing care, certainly what we know is that the hallmark of a good recovery is what people do following formal treatment. And I may have mentioned this to you before, but I like to take a look at blue zones when I help individuals develop a recovery, and aspects of a blue zone that contribute to quality of life and longevity of life. And when you look at that, you realize that there's a lot of things that that are similar in blue zones that can be implemented, or placed within a patient's treatment plan, that's going to promote recovery as well as longevity and quality of life. Retention, the founders of AA really, they recognize that the longer a person, attends AA, the more frequent they go, the more involved that they become in the fellowship, the more likely they are to succeed. 90 meetings in 90 days. Really, that's all about. It's all about retention. It's all about developing a system of support outside of a formal treatment program. And what we know is that camaraderie, taking a mentor, making a commitment at a meeting, really helps to engage the individual in the recovery process. So promoting retention, providing a supportive environment, providing those positive incentives, including coffee. There's nothing, I know that the patients that we've worked with have always enjoyed having snacks or a cup of coffee or things available. If you can, transportation is huge, especially in some of the metropolitan areas, but also in the more rural areas, it's difficult for people to travel a couple hours. And so fortunately we do have remote sessions, through Zoom or WebEx or things of that nature. Having flexible hours, not just having 9 to 5 or 9 to 6, or having hours that way, but also having evening hours or weekend hours, so that it can give patients an opportunity to go to work or take care of their educational, family responsibilities if necessary, and yet allow them to come in on off hours. So that's always important. I know it's a challenge for some programs to run extended hours, 16 hours a day, but the reality is that it's a challenge getting these people in, and any roadblocks that we can sort of eliminate and make it easier for patients to come in, excuse me, the better off we're all going to be. And then telephone or text outreach. If somebody misses a session, we want to reach out to them and make sure that they come in. The fact is that we, as a profession, haven't done really that great a job at engaging patients. One of the things that my dentist does is, prior to an appointment, they'll phone me, they'll text me, and they'll email me to make sure that I get in for an appointment. Our profession has looked at this as enabling, but the reality is that our patients, in many instances, are so cognitively impaired that as soon as they walk out the door, they forget that they have another appointment, and life gets in the way. And so there are things that we should do to promote retention, to promote attendance, and certainly using smartphones or texting or phoning somebody to remind them of their session is not against the law, and certainly it does promote it promotes attendance. So the components, as I've been talking about, are orientation, engaging, using MI, using incentives. And now I'll talk a little bit more about the drug cessation groups. The drug cessation groups there's 4 of them. Generally, we have them once per week, and it's really used as a way to socialize patients who may not have ever been in a group before, and get them sort of exposed to other individuals who are in treatment as well. The recovery skills group is a group session for 12 weeks, again using CBT and CRA to promote recovery. We have weekly individual coaching sessions that allows for the counselor or the therapist and the patient to meet individually, to help them to develop new behaviors, to follow through with monitoring exercise, or to help them ultimately schedule their time as well, to address certain challenges that they may be having in recovery. And then there's the continuing care group, and the continuing care group, or as Francis says, might be aftercare, but it is continuing care, and ultimately what we want to do is to it's beyond the 12-week program. Generally, it would be great to have it as a once a week program where individuals can check in. We can provide a topic for review that is pertinent or relevant to some of the challenges that people are facing, and keep that sort of connection to the program in the event that somebody starts to move towards using or returns to substance use. We can re-engage them in the process and get them into care again. The trust, when we talk about the trust, and I mentioned this a little bit previously, it's presented as a twice a week intervention for 12 weeks. And it would really qualify not as an ASAM level 2 program, but as an ASAM level 1 program, because it is 9 or fewer hours per week. That being said, you could augment it. You might be able to include aspects of trauma-informed care. You might be able to use it with brief strategic family therapies, or DBT. So there may be other sort of aspects of care that you would want to combine with trust to make it to achieve a ASAM level 2 an intensive outpatient program. And what we know is that people with stimulant use disorders generally initially need a higher level of care, and maybe that they're admitted to a residential, a 3.1 residential program, or higher for that matter, if they have some medical or mental health issues that are uncontrolled, and then step them down to an intensive an IOP or an outpatient program once they've gotten a little bit more stabilized. In addition, higher levels of incentives can be used. I know Tyler's on top of this in terms of what's going on with the state of Florida. So you can reach out to Tyler. I hope that's okay, Tyler, that I offered this up. But you can reach out to Tyler as it relates to what the incentives are going to be like in the state of Florida. So our training program, what we've been doing with other states, in particular West Virginia, Montana, California, is that we have 8 2-hour remote training sessions that are 8 consecutive weeks. Then we meet with the staff of those programs bi-monthly for 3 months, so that we can talk about implementation issues and challenges in implementation that folks are having. And then we meet monthly for 7 months remotely. And so really, the importance of training really is the follow up in the TA calls. We want to help people be able to troubleshoot some of the challenges that they may be having in implementation, in addressing some of the challenges that they're having with some of the patients that are entering their program. And so that it ends up being, it's about a year-long training program that we've developed for centers, and what you're getting right now is somewhat of a brief overview of that. We do collect data in those programs so that we can see how patients are doing, how patients are being retained, the level of incentive that patients are earning, and whether or not that actually translates into a productive recovery, whether or not people are reducing or ultimately eliminating their stimulant use. And this is just what it looks like. Basically, we cover each of the chapters, including we provide an overview, the therapist orientation, some aspects of MI, and then what is the cost of this training. And I can send you all a cost sheet for this year-long training. We do review the drug cessation group, recovery skills group, and we go over the topics of those and how to implement it. There's individual coaching session. We do a number of role plays, around utilizing motivational interviewing, around the incentives, and as it relates to some of the topics that are in the model. Again, the components, I'm not going to go into detail on this. I'd rather spend a little bit more time on some of the individual and group sessions, but we rely heavily on MI and open-ended questions using affirmations and reflective listening. We do spend a fair amount of time on CBT and community reinforcement approach. I talked yesterday about CRA and the value of helping individuals control their environment, change their environment to compete with sort of the rewards that stimulants provide. We know how strong stimulants are, and we need to be able to compete with them in such a way that it involves aspects of a community, including maybe spiritual leaders, including family members and friends, and educational or employment supports as well. So the drug cessation group, the format here, really what we want people to do is to get familiar, get comfortable being in a group situation. We have people introduce themselves. We talk to them about describing what brought them into treatment, ultimately what they hope to gain from treatment, and what their aspirations are. We spend time on a group topic and completing the worksheets. We always include patients as volunteers to read the topic, and of course nobody's forced to do that, but inevitably people like to do that. People like to read the topic. We provide time for patients to complete the worksheet and to share sort of the aspects of the worksheet that sort of are meaningful to them, that might relate well to their recovery, and then we wrap it up, with the group leader or group facilitator really bringing together all the comments that patients have shared, all the information that patients have shared about their recovery as it relates to the group topic. Every group that we facilitate includes, and whether it's an individual session or a group, includes scheduling. And really our goal here is to help patients create a plan for every day, develop ways to avoid being triggered, help them to engage in those pro-social activities that ultimately will help them to either obtain employment or engage in educational pursuits, whether or not it's improve communication with their family members. Really, what we're trying to look to do is to help them become productive members of society, and however that might look, and that really does vary for each individual who enters treatment, as much as it does for all of us, what we view as being productive. Every session ends with scheduling, with patients developing somewhat of a rough draft of what their schedule is like until the next time that they come in. During the orientation session, we review scheduling with them, and then once patients in the group or individual session have completed a schedule, we review their schedule with them, and we talk about potential challenges that their schedule may have or may hold for them, and we talk about things that they might be looking forward to, or for that matter, not be looking forward to over the next couple days. This is what a schedule would look like. The material on the left is a description of what scheduling is. We talk to patients about sort of the value of scheduling and why it's important to write it down. And then we actually have them go through and write out the scheduling. Initially, scheduling can be a challenge for patients. And so usually one of the things that I like to do is I like to have people, write down what they did yesterday. Do me a favor. I know that it's going to be difficult for you to write down what you want to do tomorrow or the rest of the day, but write down what you did yesterday, and let's take a look at that. And that gives us somewhat of a foothold so that we can sort of develop a schedule moving forward. And certainly what we know is that people who are engaged in employment or educational pursuits, it's easier. It's certainly a lot easier for them to schedule than if they're not employed or not going to school. Another topic is drugs and drugs paraphernalia. And so we help individuals, we guide individuals to help make their environment a safe place. These are things that you probably have done on a fairly regular basis, with patients, and it's crucial because we don't want those little landmines sitting around in somebody's room or in somebody's house, just waiting for them to explode and to trigger a return to drug use. We talk about drug using friends, and certainly this can be a real challenge for patients, especially if they have long-term relationships that either include family or friends that have involved drugs, and it might even be a partner, and how do you manage those sorts of things when it comes to helping people make decisions about who they associate with and who they shouldn't associate with. That can be a real challenge. We review the common challenges, again, drug using friends, drugs and alcohol in the home. I grew up in a family where every family event included a case of Coors beer and a bottle of Chivas Regal. And so when I went to other families, of family events in my friends or other families for that matter, I was always surprised that there wasn't as much alcohol as there wasn't in our house, and that people could still have a good time. We talk about emotional triggers, such as anger and irritability, boredom, loneliness, feeling shame or feeling guilt of some of the things that people have done, throughout the course of their recovery, that they're not proud of, and how to manage that, and how to sort of manage the emotional states that go along with those sorts of things. we talk about, holidays and anniversaries, and for many people, they've never had a holiday or never gone through a holiday or celebrated a holiday where drugs or alcohol weren't involved. And so it's an ongoing challenge for people, especially with anniversaries and not so good anniversaries, maybe death anniversaries that can be very challenging to people and can be very emotional. And one of the ways that people have sort of muted those emotions is by using substances. We talk about triggers and thought stopping, and I know that some of you, talked, earlier on in your comments of being spiritual, of meditation, and engaging in these sorts of in those behaviors that to help to settle a person down, to reduce anxiety, and these are also ways to stop the thoughts about using, and to stop the glorification of substance use. Prayer, talking with somebody, doing housework or yard work or going for walks, hanging out with the kids or the pets. There's so many different ways that we can address triggers, but the reality is that we have to help train people to be able to do those sorts of things. This is a topic on triggers and thought stopping, and really what we're trying to do is to interrupt that process in such a way that that people don't experience a powerful physiological response that they believe can only be remedied by using, or will only go away if they use. And a lot of people actually do believe that. So techniques for thought stopping are, visualization, prayer, meditation, taking a rubber band, wearing a rubber band, and snapping it against your wrist, and sort of reorienting your thoughts to something other than using. um, Talking to people about the brain and recovery. It really helps patients to understand sort of how they've conditioned themselves, or how they've been conditioned to use substances. And understanding that process is really powerful. Understanding that their brain has been significantly impacted by their substance use, and especially as it relates to stimulant use. But it's that automatic the conditioning that people don't necessarily understand. And I think when we review this with them, it sheds some lights on why they behave the way they do. So this is the topic on your brain and recovery. And as I mentioned earlier, Rebecca or Tyler or Eric will make the handbook, the patient handbook, as well as the therapist guide available to you. You're welcome to use it however you deem appropriate within your organization. The Recovery Skills Group is a 90-minute group. Really, it's in many ways it could be used as a relapse prevention group. We're looking to continue skill development and do some role plays, addressing sort of those, not sort of, but those real life challenges that people experience. The topics were developed and taken from the community reinforcement approach, which was developed by the National Institute on Drug Abuse, but also the Matrix Model CBT manual. You can substitute other topics in there that you find relevant. It may be based on different cultural expectations. It may be based on geographic regions that we may not have included. And so you're welcome to mix and match. If it's a DBT topic, or whether it's a topic that taken from Texas Christian University materials. It might be, you might want to address anger management in some of the patients that you see, or you can certainly roll in aspects of trauma-informed care, whether it's Lisa Nazovich's work, or Stephanie Covington's work, helping men or helping women recover. So one of the topics, and it ends up being really one of the favorite topics of the recovery skills group, is mooring lines, helping people to um, uh, identify specific behaviors that have helped them to promote their recovery, and at the same time helping them to identify those aspects of their life that will take them back towards using. And this is a topic that is repeated over a period of time, because what we know is that what has helped you stay drug free at one point in time might not be helpful, a month down the line or 2 months down the line. And so we know that people's recovery develops and becomes more sophisticated over a period of time as they spend more time understanding their behavior, understanding what recovery is about. And so that is one of the reasons why we have this as multiple multiple sessions over a period. So we talk about return to drug use. We talk about interrupting the process and figuring out what is best to help you maintain your recovery over a sustained period of time. And so when we write these things down, we can use these as a journal, and we periodically go back through and are able to recognize sort of what is sustaining our recovery, what we're avoiding over a period of time. And as I mentioned, things change. Our sophistication as it relates to sort of behaviors and thoughts around recovery change and develop. Recovery skills group sessions 2 and 3 are looking at internal and external triggers. We help people to recognize triggers, avoid them when possible, and when not possible to avoid, we want them to be able to cope or to be able to manage their triggers. Really, our goal is to prepare people the best way we can to be able to combat the nature of substance use, to be able to develop an early warning system in such a way that they can anticipate when things are going to be a challenge to them, and to intervene on their own when necessary. And if they run into challenges there, to be able to bring in other people, and whether it's a mentor, whether it's their therapist, or a sponsor, to help them overcome those challenging periods of time. This is the internal trigger questionnaire, and we help them to, we review this with them, and they're the ones that are identifying aspects of their environment, aspects of their own emotional sort of behaviors, that their own emotion and behaviors that contribute to return to drug use. We're with external triggers, we're looking to evaluate their environment and certain times of day or behaviors that contribute to their substance use. We ask them to take a pretty in-depth look at these things, helping them to identify things that people and places or situations where they could be in and not use substances, because it's not just identifying the challenges of recovery, but also identifying support systems within their recovery, within their environment, that they might be able to engage more in such a way that it supports, it's more supportive of the recovery, but additionally it's something that they can rely on, or somebody that they can rely on for support. Sorry about that. Here's a trigger chart where we help people to identify people, places, situations where they never use, and people in places and situations where they always use. And so what we do know is that, involvement in situations where they always use makes them more vulnerable, and certainly increases the likelihood that they're going to use. If they engage in those safe activities, safe behaviors, if they're around people who don't use, they're less likely to use. It's pretty simple that way. But the challenge is to get them to be able to recognize those situations that are going to promote their recovery. The individual coaching sessions really provide patients with an opportunity to discuss things that might be challenging. For instance, sex and recovery. For sometimes patients don't like to talk about their things that they've done as it relates to sex, while they were actively using, and so it gives them an opportunity to talk to and share in an individual session. One of the resources that I like, and I'll put this in the chat, is called it's by Douglas Braun Harvey, and it's Sexual Health and Recovery. This is a really good read as it relates to addressing sort of sexual activities or sexual behavior while somebody is in recovery. This is really helpful, and it addresses topics with MSM as well. So this is something that I would recommend that you read and incorporate in the topic around sexual health in the patients that you're working with, especially those who are stimulant users. In terms of the individual coaching sessions, really what we want is for patients to have a one-on-one session where they can develop with their counselor individualized recovery plan, and it can be combined with the incentive program. You might give incentives during either the group or the individual session. It provides patients with that one-on-one care where they may not feel as comfortable not just sharing about their sexual activity in during their use, but other aspects, maybe relations, with their family members or with their children, or challenges that they're facing within the criminal justice system. So the format is a 45-minute session once weekly. There's 12 individual sessions, and it's a balance between doing the check-in, covering the topic, exploring sort of what's gone on with the patient, since the last time that you saw them, and some of the current challenges or aspirations that they're looking towards. Generally, a topic can be covered in about 20 or 25 minutes, and what we recommend is that the individual session be scheduled at a time that's not contiguous with the group session. So if you have the group sessions on a Tuesday, it'd be great to have individual session on a Friday or Mondays and Thursdays, spreading out so that you can anchor the week for the individual, and not put them back to back. Exercise, if you can get your patients engaged in exercise, that's going to be incredibly helpful. It's gonna help structure their time, which is useful. It's going to improve their mood. It's going to improve their cognitive capacity as well. Obtaining a medical clearance is going to be important, or certainly going to be helpful. We don't want people to injure themselves, when they engage in exercise. And yes, I like that, Francis. just move, but move at your own pace. Absolutely. Anything that we can get people, any way we can get people engaged is really helpful. Thanks for sharing that, Francis. I appreciate that. Factors to consider in terms of exercise is convenience, helping it fit into your schedule, not being so rigid. What the literature has shown in terms of exercise is that people who are so rigid and say, look, my schedule, I have to exercise at 10 a.m. Well, if something comes up and they're unable to exercise at 10 a.m., those people who are so rigid tend to not exercise at another time of the day that they might have available. And so, not being so rigid, you know, finding a comfortable setting to exercise, whether it's in your home, or whether it's a gym that isn't so intimidating. Finding something that's affordable. Some of the parks here locally have exercise equipment that's available at the park that you can engage in. It doesn't have to be incredibly sophisticated. I mean, it can be something that, skating or biking or shooting hoops on your own, going for walks, going for hikes, and pairing it up with people that you care about, pairing it up with people that you're familiar with. But as Francis said, start slowly. Exercise, shorter exercise. Yeah, walking out your front door. I mean, that's, there you go. Just getting outside. And certainly it's easier in springtime, in parts of the world that you and I live in North Dakota. It might not be so easy, but certainly in places like that, they have winter sort of they have winter activities that they engage in, whether it's snowshoeing or whether it's going to the mall and getting their walks in, or going to the gym. They're incredibly resourceful in those parts of the world as well, where the weather can be a real challenge. Returning to sports, yeah, make a snowman. Return to sports that you engaged in earlier as a youngster, or things that you engaged in. Finding somebody to partner with. Keeping track is always useful. We have Fitbits and smartphones that keep track of things these days. Keeping track on your calendar with stickers, and sort of being able to recognize those things that you've been doing over a period of time. And it feels pretty good when you look back and you say, wow, I've got 3 days in a row, or I've got 4 weeks in a row where I've engaged in some sort of exercise. And then our individual coaching session, we do have a topic that we review as it relates to exercise. And then again, I talked a little bit about this earlier: Stimulants and Sex. That book I would certainly recommend, and it'll give you some ideas about how to engage patients in that conversation that can be challenging for some, and sometimes it's best to address this individually. And then our continuing care plan, and what we know is that and you all know this. I mean, 12 weeks isn't what recovery is about. I mean, it's a good start, but recovery, like any other chronic medical condition, needs ongoing care and ongoing attention. And the more we the stronger of a recovery that we develop during that first 12 weeks, and we can continue to support the individual through the continuing care plan, more likely they are to be successful. Having those periodic check-ins that and engaging in continued outpatient care for individuals ensures that they're going to be more successful in recovery than just sort of graduating them, or saying, hey, you've completed your recovery, you're good to go, the way we used to do, unfortunately. But certainly keeping people engaged in recovery improves the likelihood that they are going to be successful. Aspects of the continuing care group, and then transitioning people from to the continuing care group. One of the things that we recommend is that the counselor that runs the continuing care group is the same counselor that ran the individual sessions, or that ran the drug cessation group. Ideally, having that continuity is really important, so that people will make the transition to continuing care, where otherwise it might be a challenge for them to enter a new group situation. People might feel a little less uncomfortable. Incentives, just briefly about incentives: never give money, never give cash for incentives. Incentivize only drug-free or stimulant-free UAs, and the incentives should never exceed $75. Ideally, you want to front load the incentives, present them with praise and enthusiasm, maintain security for your incentives. That's crucial. Have one person who's responsible for monitoring and maintaining those incentives. You're going to keep your organization out of trouble when you do that. And I want to thank you for your attention, and open it up we got about 10 minutes for questions here. Thank you, Jane.
I do see one question that was sent to me directly, and it is, do you have any research on the socioeconomical profiles of individuals whose incentives are effective?
Wow, what a great question. I don't off the top of my head, but I can look at that and see. I mean, that really is a great question. Certainly, what I would assume, and I'll see, and I'll ask some of my colleagues around, if they work actually better for people who have modest incomes versus people who have significant incomes. I will look into that. I don't know. My assumption would be that for people who have lower or modest or no incomes, I would just assume that the incentive would work better, but that may or may not be the case. Great question, though. Let me look at that, and I'll get back to you with this, Rebecca, and maybe you and Tyler can pass it out to the group. Okay.
Okay, and then we have a couple people asking about the therapist guide, so I will just go ahead and clarify that will be posted on our training library with this training.
Okay, good. Yeah,
that way everybody can access it.
Yeah, and you're welcome to use it. I mean, we didn't develop this for that reason. I mean, it's ideally we'd like to see if find out if there are some recommended changes that you'd like to you make to it, if you implement it, if there's something that you find useful. Let us know. If there's something that isn't useful that you'd like to change, let us know. We're taking any and all feedback at this point in time.
Well, I don't see any more questions in the chat, so I will go ahead and conclude today's webinar. This is the final series in the three-part series for this week. We will have it again at the beginning of April. So thank you, Mr. Hassan, so much for today's information. It was really great. As you can see from the chat, you're getting quite a few praises. So it was really great. And we thank you so much for all the work you put into it.
Thank you, Rebecca. I do have a question. Did my cutting out, did that improve or did it stay the same?
It completely went away, so you were able to
Okay.
it.
All right. All right. Thank you very much. I appreciate that.
Of
Sorry about
course.
that.
No problem, of course. Well, thank you so much. And like I said, this is a three-part series. It will begin again at the beginning of April, and it will be with Dr. Rawson and Mr. Hassan again. So if you are interested or know someone else who might be interested, please pass the information on. We'll be announcing that shortly. And once again, thank you, Mr. Hassan. We really appreciate all your work you put into this.
Thank you.
And just so everyone knows, today they're in a couple items of business before we conclude. In the chat panel is a link to today's evaluation. In order to receive, you will need to take the evaluation on our website. You will also get a second opportunity as well. You will be prompted to register or sign in for the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, please make sure you have an accurate Florida Department of Health license prefix and numbers when you register with our site. After you register or sign in, you will be directed onward to the evaluation. You will need to use the same email address you used when you registered for our webinars as what you have in your FADAA profile. That is how we connect your attendance to your profile, and that's how we issue CEUs and statements of credit. You will get a second opportunity to complete the evaluation through a follow-up email later today. The sender will be messenger@webex.com, and the evaluation will close midnight, Tuesday, March 29th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. This will happen 30 business days after this event. You can go to our frequently asked page on our site and you can see how to view your statement of credit within your profile if you do not know how to recover it from your journal entry. Thank you for participating in today's webinar. We'd also like to recognize and especially thank the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. Thank you so much, and I hope you all have a wonderful rest of your day.